Hello, my name is John Buscombe. I am a nuclear medicine specialist from the United Kingdom and the immediate past president of the British Nuclear Medicine Society. And I'm going to share with you some of my thoughts about SPECT-CT in present status and perspectives. I would like to give the welcome and our felicitations to the Hellenic Nuclear Medicine Societies from the British Society, and also to remember that this is the 200th anniversary of the founding of modern Greece, which of course did involve at least one very strange Briton, Lord Byron. So in terms of disclaimer, I have done a talk for GE Healthcare on SPECT-CT, but they managed to forget to pay me, so I'm not sure that counts or not. So I'm going to talk about the use of SPECT-CT in endocrinology, oncology, MSK, infection and lungs, and a little bit on new advances. Starting with endocrinology, the most common use of SPECT-CT is in parathyroid tumours. The diagnosis is done by blood tests. We're really involved in localizing the tumour, first of all to determine if it's in the normal space behind the thyroid, if it's upper or lower pole, left or right, which will help the surgeon, particularly with minimally invasive surgery. Also, a second look if a patient has had surgery and they can't find an adenoma. Is it still present or is it ectopic? So traditionally, we've used subtraction techniques where we inject two tracers, one which is taken up by both thyroid and parathyroid, and another one, for example, potentiotate of iodine, which is taken up just by the thyroid. These are subtracted, and then hopefully what is left is the parathyroid adenoma. And this is done basically on planar imaging. Alternatively, you can use the washout technique using something such as MIBI. Tetraphosphine doesn't work with this. And what you do is you inject the MIBI, you scan about 15 minutes to give you a thyroid scan, and then you wait 2 hours, and then you do a further image, and you can subtract the two images, or you can do SPECT and now SPECT-CT. So this is a washout planar scan. This was done in 2005, and you can see here that you get washout of thyroidal activity. This patient has nothing else that we can see on them. So SPECT-CT enables us to both find if there's any abnormal uptake, but also enables us to localize this. And this is based on some work that was done and published in the World Journal of Surgery. And this was done in Israel and showed a 39% improved localization with SPECT-CT, and in particular was able to find ectopic parathyroid adenomas. And the image that I'm showing you here has got an upper mediastinal parathyroid adenoma, and this was done on a machine, very old type of machine using a flat panel CT, which was done at the Royal Free Hospital. But with more modern SPECT-CT cameras, you can find smaller tumours and localize them more precisely. This is also done on a Siemens camera and about a decade ago. And this shows again another mediastinal parathyroid adenoma, for which we can localize very precisely using SPECT-CT. And for the surgeon, this is essential to be able to plan surgery. Also, even when it's in the neck, it can still be ectopic. So, for example, this is a patient who has uptake in the neck. This is a patient from Cambridge. And we can see here that there is focal uptake of retained MIBI at around about 90 minutes. But when we localize this, it is actually retropharyngeal, and that requires a different approach than just an ordinary parathyroid adenoma to avoid damage to the recurrent laryngeal nerve. If we move down the body, we can get to the adrenal medulla, and the tumors of the adrenal medulla is pheochromocytoma. Again, the diagnosis is biochemical by finding increased catecholamines in the urine. And we use iodine 123 or 131 MIBG. For imaging, we prefer the iodine 123, even though it's more expensive, but it's not available everywhere. And these are amines which are taken up into the tissue we know via things called the VMAT1 and 2 genes. But we do need to stop any drugs which interfere with the MIBG uptake, and these tend to be old-fashioned antihypertensives and drugs like cocaine and alpha and beta emitters. Because of using iodine as our radionuclide, we do need to protect the thyroid with either potassium iodide or, more commonly these days, if we can get hold of it, perchlorate. So this is a patient who has a large pheochromocytoma seen on the whole body scan. And we know that there is the rule of 10%. So 10% are malignant, 10% bilateral, 10% ectopic, 10% are found in children, 10% associated with syndromes such as MEN2 or the von Hippel-Lindau. And then 10% of them will be negative for MIBG. Now, this is actually the same patient, but this is after that large tumor had been removed and the patient continued to have raised catecholamines. And this is a resulting RD123 MIBG SPECT-CT, and this demonstrated a small area of residual tumor that had not been removed surgically, and the surgeon had to go back to remove this. This is done on a GE camera at Addenbrooke's, and you can in Cambridge, and you can see here this is a 15-year-old who had an abdominal mass. We weren't sure what it was. We didn't want to remove it if it was a paraganglioma or a pheochromocytoma without sufficient alpha and beta blocker cover, because the patients can get severe hypertension, even stroke, or die on the table if you don't do this. So we did an MIBG, and this shows rather low grade uptake you see on the whole body, but with the SPECT-CT you can clearly see uptake within the tumor mass consistent with a malignant paraganglioma, and this was removed safely. In oncology, we may look at specific agents, for example, somatostatin receptor imaging. We may look at RD131 post-therapy. Sentinel node localization may benefit from SPECT-CT, and for pre-dosing of SIRT. So somatostatin system, we know that this is most commonly directed to the type 2 subtype. You can use indium pentetrotide, but this is not always available. And most people have now moved to technetium-labeled either HYNIC TATE or HYNIC TOC. Different agents are available in different countries. And these are mainly used for imaging of NETs if we don't have, for example, PET with gallium-68 dotatate available. So this is from the Royal Free Hospital. This is a patient who has got large liver metastasis, but I'm not going to show you the SPECT-CT at that site. If you look at the arrows, we noticed that there was uptake in the pelvis. On a whole body image, we might have thought that this was bladder or urinary activity. We might have thought even the same with SPECT, but on SPECT-CT, you can see that the upper arrow corresponds to an obturator lymph node with uptake, and the lower arrow is in fact not urinary activity, but a lytic metastasis in the pubic symphysis, something which we probably would never get without SPECT-CT. We could also use this to improve specificity. This is a patient from Cambridge, and on the SPECT alone, it looks like this could be colonic activity, which we often see with this is with indium octreotide. But when we do the SPECT-CT, what we actually find that these are peritoneal metastasis, and therefore we can add specificity to our scan. Also, remember, we can find and identify unusual metastasis. So this is a carcinoid with a metastasis within the back of the orbit. And this kind of metastasis does require to have urgent surgery to save the patient's sight. In terms of publications, most of these are fairly old, but again, they confirm a 20% increase in localization using SPECT-CT over SPECT alone. And this changed management in 24% of patients compared to 14% with SPECT alone. But the conclusions are the conclusion that we normally get, which is that SPECT-CT improves our confidence in reporting. There's a meta-analysis that was performed in 2009, again showing that whatever site you have tumor in, that your confidence in reporting is improved immensely with SPECT-CT, particularly in things like the pancreas and lymph nodes, where it's difficult to identify exactly where uptake is unless you have SPECT-CT. Technetium HYNIC TATE can also be used. This is much more widely available now, but this is produced by Poland. Its development was initially restricted by European Clinical Trials Director, but I think it's now been licensed almost across the whole of the European Union and also in the UK and several other countries as well. It's much cheaper than the Indian product because you don't have to buy expensive indium. And this is taken from one of my colleagues in Warsaw. In the early development of this tracer, showing you can get very good quality images with the Technetium product. In fact, you can get almost as good quality images as you can with PET-CT, but obviously until very recently, we were limited to which part of the body we could do a SPECT-CT in terms of the time of acquisition. iodine-131 post-therapy, publication again about a decade ago, showed 48 patients with differentiated thyroid cancer that had iodine-131 SPECT-CT after their therapeutic dose of iodine-131. And they showed that there were a different result when you use SPECT-CT. Most commonly, patients were reported on planar as having residual uptake in the upper neck, but with SPECT-CT, this was found to be in the esophagus. However, in a few patients, additional lesions were found which were significant, and the patients were restaged into a higher stage. So this is an example of a patient who was scanned 4 days after treatment with 3.7 gigabecquerels of iodine-131. All you can really see is neck uptake. And this is a patient, again, from Cambridge. So we did a SPECT-CT. And yes, indeed, there was uptake in the thyroid bed. But very carefully, we could see there was a little dot in the posterior part of the thorax. And SPECT-CT demonstrated there was indeed a metastasis in this stage 1 thyroid tumor as stage before the iodine-131 SPECT-CT. And if you look very carefully on the CT component here, you can see there is a lytic bone metastasis in the spine. And this clearly changed the whole patient management. The sentinel node, where can we use this in sentinel nodes? Well, we know that if we look at the Cabanas and Morton principle of sentinel nodes, is that the sentinel node is the first draining node that we have from a tumor. And if this is positive, then there is a possibility of nodal spread elsewhere. But if this is negative, it's very unlikely that there is nodal spread. And we have found this to be most useful in melanoma, because in truncal melanoma, that is in head, neck, thorax, abdomen, and pelvis, the lymph flow can be unpredictable. So unlike breast, which tends to predict going to the axilla, it's unpredictable with melanoma. So we find that additional imaging is useful. It can also be used in some oral cancers as well. So this is one of our patients who had a head and neck melanoma, and the primary is just by the ear, and you can see here that the nodes are very close to this. And this can also assist in helping the surgeon in removal of abnormal lymph nodes. And this is with a new agent called tilmanocept, and this is an oral cavity tumor, and you can see the injection just in the bottom of the mouth, just here under the tongue. And you can see very nicely that very quickly, within 30 minutes, you can see with a SPECT-CT sentinel lymph nodes in the neck. And this expands the role of sentinel lymph nodes in different types of cancer. This is not possible with planar imaging. You need to do SPECT-CT. In planning for selective internal radiotherapy with either Y90 SIRT, which is SIRT-X, which is a radio-labeled resin, or TheraSpheres, which is radio-labeled glass beads, we perform a Tc-99m MAA SPECT-CT. Now, if you're using holmium, then you can use the gamma emission from holmium, so you don't need to use a different agent, but you still need to do a spot test view, and we do this to look for both shunting, but also we can do this to look for the expected distribution of the agent and how this may affect the dose delivery. Then following treatment, we can do bremsstrahlin, SPECT-CT, using the scatter that comes off of the after the beta emissions to find out actually where the product has gone. So here we have on the left-hand side where the arrow shows, this is a MAA scan, which did show some activity in the falciform artery. However, the MAA particles are slightly smaller than the Y90. So when we did the bremsstrahlin SPECT after therapy, we didn't find that there was any activity in the falciform artery because it's a very, very tiny vessel. So we tend to ignore MAA activity in the falciform artery. If, however, for example, there was an accessory vessel that sometimes supplies the upper pole of the right kidney, we would then know that we need to embolize that before we give the SIRT. So we can use the MAA to plan the SIRT treatment. And again, SPECT-CT is vital for this. Let's move on to musculoskeletal disease. And here, the main priority is the localization and specificity. Maybe some increase in sensitivity, but again, because we tend to be limited with a normal SPECT-CT camera to 40 centimeter field of view, we may only be able to image one joint or one area. But remember that outside of the chest, abdomen, and pelvis, where there's no red marrow, the additional radiation dose from the actual CT component is limited, and you may want to use a higher dose CT to deal with metal artifacts, for example. So this is a paper that was published in the Journal of Nuclear Medicine Technology from Australia. They showed 80 patients with a solitary site of increase of uptake in the spine, and the site of lesion was identified correctly in 6% on planar imaging and 79% with SPECT-CT. And the 31 false negatives on planar was reduced to just 7 with SPECT-CT, and this was compared to MR and final clinical diagnosis. This is actually one of our cases of a patient with a single area focal uptake within the spine, and SPECT-CT demonstrated that this was due to a partial osteoporotic collapse, and it was not a metastasis. We can use it in different parts of the skeleton. So this is the paper from 2021 in HYNIC research. They looked at 51% of patients with wrist pain. 48 lesions were seen on planar X-ray. 117 lesions on planar bone scan, but 142 lesions with SPECT-CT. And SPECT-CT changed the management in 37% of patients with wrist pain. And you can see here, we got a planar uptake in a patient who's fallen over, and it looks like it's in the site of the scaphoid. But when we do a SPECT-CT, it's actually localizing to soft tissue damage, and the bone itself is not damaged. So again, showing you specificity with SPECT-CT. What about other areas, hips and thighs? Metal is often an issue because most of these patients we're scanning have had hip replacements or screws in place, and this can result in a false positive hotspot. So you need to look at non-attenuated and attenuated corrected images as we would with PET. You can get effective steal of counts from bladder activity, so you just need to be aware of that and be careful when you're looking, but they can be very useful. Here, for example, is a patient with a painful hip replacement, and in fact, when you look at it, you can see that there's very little activity around the actual hip joint, just a little bit of uptake around the proximal end here, which is characteristic of what we see in a patient who has had a hip replacement, but there's no significant increased uptake around the prosthesis, which makes infection or loosening unlikely. So this kind of information will help the surgeon. Just to finish off MSK, we can do knees as well, and there's a lot of data on that, but I'm just going to finish off with the feet with some work that we did, which was published in the World Journal in 2017, and that's free to download. And we looked at a series of patients, 60 patients imaged with SPECT-CT of the feet, and only one study did we really fail to find a diagnosis, but we managed to change management around about half of our patients. And there's a whole range of pathologies that we found in patients who just presented with a painful foot, including missed fractures. And this was one of our patients who had had a fracture, known fracture, and they had it fixed on the medial side, and you can see the screw on the medial side here. But what they missed was that there was an avulsion fracture of the lateral malleolus, and this was still metabolically active with a distressed ankle joint. You can see there's uptake around the lower tibia and the talus. So what they had failed to do was to fix the lateral component, and this had resulted in continuous mechanical stress. What about infection and SPECT-CT? Well, this is an area I particularly find SPECT-CT very useful, because planar imaging may tell you there's abnormal uptake, for example, of either white cells or gallium, but it doesn't tell you what's causing it. Now, what agent you use is up to you. It depends on the clinical picture, availability and cost, and imaging characteristics. And obviously, if we could use technetium or indium, that would be preferable to using things like gallium. But gallium may have a role in certain cases. This was a patient, there was a case report we published, and this was a gallium uptake in an infected renal transplant in a patient. Now, the problem is that we couldn't use labeled white cells because the patient didn't have any, because they were immunosuppressed. We couldn't use PET because FDG has excretion through the normal transplanted kidney. So we used gallium because after 24 hours, there is no renal activity in a normal gallium scan. So this diffuse uptake in the transplanted kidney must be due to infection. We use labeled white cells now in the UK. It's traditional for us to label white cells with technetium HMPAO or indium oxine. In other countries, you use Syntium, which is a technetium labeled antibodies. But again, it doesn't matter which of those techniques you use, SPECT-CT is very useful. And again, it's because it can use, you get really good localization. And we found this particularly useful in diabetic feet. Now, the first paper to show this came from Israel. This is from Buscombe et al. In the JNM in 2006. And even then, they showed a 48% improved localization. This was a classic example. So this is a patient who's had a vascular graft. And if we rely on panel A, which is the planar image, we can see uptake overlying the graft. And we may be tempted to say that's an infected graft. But the infected graft is a big operation. That graft needs to be replaced, and there's a high risk operation. If we do SPECT, which is part of the middle image on panel B, you can see focal uptake, but it looks quite peripheral. And if we look at the CT scan, which is the third panel, the last panel along on the right, we can see that in fact the uptake doesn't appear to localize to the vessel. But when we do SPECT-CT, which is the colored panel B, you can see in fact this is a wound infection and not due to underlying infected vascular prosthesis. So this is an advantage of using these kind of techniques, is that you can get precise localization. And in a review by Paula Alba that was published in the European Journal, they showed that in vascular infections, that SPECT-CT is the only method that had 100% sensitivity and specificity, looking in 55 patients. SPECT was better than planar, and everything was better than ultrasound and CT. These are a couple of cases from Cambridge, one of them showing a very obvious focal uptake. This was the first SPECT-CT we ever did, and it showed a mycotic aneurysm coming off of a trouser graft. The second one is much more subtle, and it shows low-grade abnormal uptake of indium white cells, but you don't get indium white cells unless there's infection. So though it's not a spectacular image, it shows this was a chronic infection in an inflammatory mass, again around a trouser graft. The other advantages, we have sensitivity versus specificity. So FDG PET can be very sensitive. So in this patient, I had an aortic valve replacement. 3 weeks later, they had a pyrexia, which wasn't settling, so they did an FDG PET study. And this showed intense uptake along the operation line here in the sternum. But they wanted to know whether or not this was actually infected or just post-operative inflammation. So we did an indium white cell scan. It was completely negative. So they were reassured that this was just normal healing. and there wasn't an infection at that site. In fact, by the time they finished this process, the patient's temperature had settled. More recently, of course, we've been able to use SPECT-CT to look at what happens in patients who have COVID. This was published from France in the middle of last year, and it shows a perfusion SPECT image with a defect which looks like a pulmonary embolism. But you can see also on the middle panel, which is with Technogas, there's very patchy ventilation. And in fact, when we look at the CT scan, we can see there are changes consistent with an infarct. So this is a pulmonary infarct, but this is related to a COVID thrombosis with very poor ventilation across the lung. And we're just beginning to learn how we can use VQ SPECT-CT in patients with COVID. What about new advances in SPECT-CT? Well, we have new iterative CT, which enables us to reduce dose. There's scatter correction, which can enable us to do CT volumes, multi-headed digital CZT cameras, and we can look at quantification with SUVs and dosimetry. So the first thing is scatter-based correction. So this basically says, can we use the CT to improve our SPECT reconstruction? So it uses the fact that we get spread function with SPECT, but we can correct for that scatter using the CT volumes. And we can see here in a paper published in European Journal of Hybrid Imaging how this can actually be done. For example, this is a SPECT-CT of a patient with metastasis in the cervical spine. But when we correct, we're using the CT for the volumes, we get much better localization. And this is seen commercially with this XSPECT system, where you can see that using 3D iteration and CT attenuation correction for the bone, you get much better localization, and you can really hone down where the abnormality in the SPECT comes from. Dale Bailey in the European Journal showed that we can use SPECT-CT. We can tune this using scatter correction to get the same kind of SUVs as you do get in PET. So we can use this for monitoring patients, for example, with various disease groups using SPECT-CT, but also we can move that on to dosimetry. So here, for example, this is actually showing quantitative uptake in a bone scan of patients, demonstrating that the uptake of MDP within bone is greater in males than in females at whatever level. And again, you can use this to localize uptake, and you can look at the SUV of various agents or raise things like metastasis and how this responds to treatment. So these are exciting new areas we can use SPECT-CT. And this can move on to dosimetry. So this is using PSMA with SPECT-CT from an Australian group, showing that we can identify the absolute radiation doses, for example, here in the carotids and within tumor, and use this to identify how we can do better SPECT-CT. And this is an iodine 131 MIBG, and we can dose map as we can do with external beam radiotherapy now, using these quantification methods with proper quantification with SPECT-CT. And this is from John Gear at the Institute of Cancer Research, showing we can actually provide absolute doses for patients we're treating. Finally, of course, is that there are now new multi-headed SPECT-CT cameras. This is a one from a company called Spectrum Dynamics, and this is the Veritron SPECT-CT. And here we have a whole body attenuated corrected bone scan done as a tomographic SPECT, and the whole thing took just 18 minutes, which is half the time it takes to do a SPECT-CT of a single site. So you can now do tomographic SPECT, attenuation corrected, or SPECT-CT in the same time as a whole body bone planar bone scan using these new technologies. This comes from Dr. Little at Bath in the UK. So in summary, single photon is not dead. SPECT-CT helps to increase the accuracy and localization of imaging and has a role in endocrine, oncology, and MSK. SPECT-CT is getting better. And remember, the cameras and tracers, even those fancy multi-headed SPECT-CTs, are still cheaper than the PET-CT scanner. Thank you very much.